Welcome, everyone. My name is Stephen Collins. I am the CEO of Matter. Today, we are very pleased to present the Pandemic Response Innovation Challenge, which we've had the pleasure of putting together with HCSC and Anthem. So as of this morning, we've seen 44 million COVID cases worldwide, nearly 9 million in the United States. 1.2 million people dead around the world, 227,000 dead in the United States alone. Infections today in 41 states are on the rise, as are hospitalizations and deaths. A few months ago, when the statistics at that time seemed mind-boggling, but have sadly proved to be really only portents of what's happened since, and what is still happening, we launched this challenge to identify and help develop technology solutions that can help address aspects of this as well as future pandemics. There's two focus areas. First is a behavioral health track, which is focused on helping people recognize their behavioral health needs, identify and activate solutions that address those needs both during and post-pandemic. And the second track is a data sandbox track. The question there is, how might we harness the data we have from the current and past pandemics to sustain and improve patient care and outcomes during this pandemic and in the future? The teams that you will hear from shortly have been selected from a pool of global applicants and will address these questions in their presentations. First, you'll see companies from the behavioral health track, and then after that, companies in the data sandbox track. After each pitch, judges from Anthem and Blue Cross Blue Shield of Illinois will have 6 minutes to ask questions. Winners will be announced following a deliberation period at the end of the program. The winner for each track will gain the opportunity to pilot their solution with one of these two firms. And that is a pretty compelling value proposition. Anthem serves more than 100 million people. 1 in 8 Americans gets their health insurance through Anthem plans. HCSC is the parent company of Blue Cross and Blue Shield of Illinois, Texas, Montana, New Mexico, Oklahoma. It is the largest customer-owned health insurance company and the 5th largest overall, serving 16 million members. These are big companies. Giving today's winners a really unique opportunity to pilot their solutions with the potential for significant scale. We have 4 judges today, 2 from Anthem and 2 from HCSC, and I'd like to introduce each of them now. And when I do, if they could just turn on their cameras and wave, that would be great. First is Steve Hammond. He is the president of Blue Cross and Blue Shield of Illinois. Next, we have also from Blue Cross Blue Shield of Illinois, or HCSC, we have Addison McGuffin, who has a system-wide role as Vice President of Strategic Innovation. And then from Anthem, we have Plamen Petrov, who is Vice President of Exponential Technologies, one of my favorite job titles ever. And Bill McKinney, who is Emerging Business Group Leader with Anthem. This is a terrific group of judges, and I'll just say that it means a lot when senior executives from organizations such as these prioritize the time, make the investment of time to engage with startup competitions and participate in competitions such as this one. So now that you've met your judges, I'd like to turn things over to Gina Konstantakopoulos. Say that backwards, please. Director of Marketing and Engagement here at Matter, who will provide an overview of our agenda and MC the pitches.
Thank you so much, Stephen, and welcome everyone to what will be an exciting day. Right now, we're just going through our opening session, but we're going to begin today with our behavioral health track presentations from 4 promising companies that are working in that field. That will go for about an hour. And then we'll move from 2:05 to 3:20 Central Time to our data sandbox track with our next 5 companies, again, presenting a variety of solutions enabled by Anthem's data sandbox. Just a quick reminder about our format. We'll have a 6-minute pitch followed by 6 minutes of moderated questions and answers. And then there'll be a short overlap where the judges can take their notes, and we will bring the next team on. So with that, I'm excited to begin with our first presenter today, Phil.
Many thanks, Gina. It's a pleasure to be here and participate in this competition. Hello, everyone. I'm George Eleftheriou. I'm the co-founder and CEO of Phil, where we make biomarkers and digital therapeutics for mental health. And the reason why we're doing this is because mental health, in contrast to any other medical field, still relies on self-reported questionnaires that are actually submitted and administered at the office of the therapist. And this lack of objective data doesn't allow us to offer support to individuals struggling with those conditions when they're outside of the therapist office. Especially in times like this, where we see a significant increase in mental health disorders because of COVID-19, significant higher numbers than the 1 out of 4 that were suffering from those disorders before the pandemic. We believe it's extremely important to be able to support with objective data and tools individuals at their home and outside of their clinician's office. And this is something that we do in every other medical field. So this is something that it's very common to individuals suffering from diabetes. They're monitoring their glucose levels multiple times a day, and similar to heart disease and other conditions. Why not have similar technologies in the field of mental health? And this is actually very possible. Since the mid-90s, over 200 peer-reviewed publications tells us that through monitoring of the physiology of individuals, we can detect their emotional state and use that as a data point to trigger interventions based on cognitive behavioral therapy. And this is exactly the 2 pillars that we're using in our disease management programs. We're using sensors that are able to monitor the autonomic nervous system of individuals and detect how they feel throughout the day. Use those data points to trigger real-time interventions when the person needs it the most, and then provide for the very first time data, objective data, to psychotherapists or mental health coaches to support them in performing their job in an effective and efficient manner. Finally, we're also providing an educational program to support individuals in building long-lasting coping skills for mental health. But what really makes us different is this close proximity that we have to the users. We can trigger interventions in real time where they're experiencing a moment of distress, and through that prevent ER visits and rehospitalizations. And what we have seen is that those real-time interventions are driving very high engagement of users. We see them interacting with our application over 60 times per week and performing over 15 mental health exercises per week, which is 3 to 5 times higher than what we see in other digital mental health applications. At the same time, we provide data to the therapist to help them improve their clinical efficiency and be able to see many more patients at the same time. So in our program, the therapist spends about 15 minutes per week per individual, and because of the data that they have in their hands. And although we reduce the time that the therapist spends with patients and participants in our program, we see significant improvement in outcomes from what we would expect to see in traditional face-to-face cognitive behavioral therapy. We see improvement north of 60% in depression and anxiety, and a significant improvement in life satisfaction. And all those are the pillars that we're using in each and every one of our programs in our platform. We have programs for generally healthy individuals that struggle with situational stressors such as COVID-19, individuals that have a diagnosis of a mental condition, and individuals that suffer from a chronic condition with a mental health comorbidity. Each and every program provides a unique experience for every member based on the data that we collect through our device. And those data are really what makes us different uh, from the rest of the competition. We see so many companies providing self-help solutions. We see many companies offering telehealth services for mental health, but very few that combine data with telehealth and self-help in order to provide both cost efficient as well as solutions that could scale and provide support to the millions that suffer from mental disorders in the country. And that's exactly the reason why we have seen major companies working with us over the past few years and in the next few years as well. We are working with leaders in the pharma, health and life insurance space in order to bring our solutions to as many people as possible. But we wouldn't be able to do this without our extraordinary team. We are extremely glad to have in our team people from companies like Able2, Sorcero Health, as well as advisors from chief medical officers from large health plans in the US, executives from large insurers, as well as academics with an expertise in psychiatry. Join us in helping the 60 million Americans that struggle with mental conditions in the US and help us provide them with real-time support and interventions when they need it the most, as well as data for the very first time to psychotherapists and coaches to help them provide support to as many people as possible. Thank you.
So very good presentation, George. Appreciate that. Excited about what you guys are doing. Digital biomarkers sound dangerous, you know. Sounds like that's not something to not know how to drive, you know, be careful with. Question, what's the hardest part, you know, with regards to the therapy that you guys provide, you know, from the standpoint of consumption, adoption, management, you know, what seems to have been the hardest part, you know, in your observations?
Sure, that's a great question, Addison. I think that depends on the population that we're targeting. We have worked with Medicaid populations, and the hardest part in that case was maintaining engagement of individuals in the program. We saw in pilots that we did with a large health plan in the U.S. focusing on Medicaid populations that we kept close to 80% of the participants until the end of the program engaged and active on a weekly basis. We saw a much lower dropout rate, 3 to 4 times lower than what they usually see in traditional therapy. However, that was quite challenging. In terms of commercial and general population outside of Medicaid, I would say the biggest issue is how to have direct access to that population in order to help them enroll and make them aware of the programs and services offered to them. And this requires significant basically engagement with the employers and the health plan in order to help them engage in our program. And something that we have been testing a lot recently is how can we reach populations that are outside of the insurance umbrella? How can we use our digital marketing efforts and experience over the years in order to acquire populations that are uninsured in many cases and provide them with the support that they need. And we have seen significant interest from that population group as well.
Okay, great. Thank you.
Excellent. I'm actually going to ask the next question to have Bill ask the next question. Bill, can you share some questions for Phil?
Yep. And apologize if I can't keep all of the solutions straight. I promise I read everything last night. But my question is, you mentioned the therapists. Are the therapists in-house, outsourced, and how would you scale with an organization the size of Anthem? Or how could you?
Absolutely. So first of all, the reason the data that we have in our hands give us an unfair advantage in scaling up the therapists and the coaches that we have in our platform, because that allows us to optimize the time of the therapist and significantly reduce the time that they need to spend with its patients. In terms of recruiting of therapists, our VP of Clinical Operations was the one who developed the network of therapists of Able2, and she's helping us build the processes, training tools, and recruiting for both therapists and coaches. So we have some of them that are in-house. We have a group of independent contractors that we're working on a continuous basis. And then we have a few partnerships that we are now expanding with therapist networks and coaches that could help us significantly scale up the number of therapists that we have. I would say though, because our therapist spends a quarter of the time that the therapist spends without the data that they receive in our program, definitely we have a very strong advantage there.
Excellent. Thank you for that. We have time for one more short question. Steve, would you like to ask a question?
Yeah, can you talk a little bit about the great presentation, by the way, very exciting. Talk a little bit about the funding model. Are you primarily direct with insurers? Are you going direct to employer? And then within that, are you engaging with the members directly? Is the monitoring device voluntary? You know, if people raise their hand, they say they want it, and want to understand a little bit on the financial piece, and then how the actual model works.
Sure, absolutely. So we are going through the insurers, through the health plan primarily, or life insurers in the US and Germany. But in many cases, it's very important that we have a close collaboration with the employers as well. You saw in the partner screen that we have a few employers that we're working with already. So that's another option that we have. In terms of the funding model, usually it's the insurer or the employer that is funding this, and also depending on the level that they want to of support that they want to offer, potentially there is a copay from the member themselves. So we have tested several of those models. And also it depends a lot on the ROI case that we make, because in many cases the advantage is how can we reduce ER visits and hospitalizations. So it has a lot to do with that part of the value creation. So yes, primarily going through insurers and employers, and it could be a co-sponsored model that we have in that case. The cost is, of course, much lower than the cost of traditional therapy, because we use much less time from the therapists themselves.
All right, thanks, Jana. Hi, everyone. I'm Ritvik Singh. I am the CEO and co-founder of wayForward. We are a New York-based digital behavioral health company. We've all discussed how common and costly mental health problems are. And one of the key things that we also focus on is how mental health and emotional wellness is really complex and is on a spectrum. So I won't really spend too much time on it, but just want to highlight how COVID has really accelerated the need. Stress levels, anxiety levels, depression levels have all spiked because of COVID, and we're going to feel the impact of that for years to come. So going straight into the solution. So our core team is neuropsychologists and CBT and DBT experts who have really built the underlying cognitive behavioral therapy based program, our screening. And together what we have really created is, from the user's perspective, it is an app and web-based platform where a user comes in. We ask them a mix of validated questions, and it's an adaptive screening. So people could be asked as few as 8 questions or up to 28 questions. And the whole aim here is to help the individual user identify what they're experiencing. Because the way the user experience right now is that people call in and they call in, even if their severity is moderate or low, they call in and go for therapy, which might not be clinically the most relevant or appropriate solution. So the first thing to get people to the right kind of care is to identify. We have very limited time, so I won't be able to show you a live demo. So I'm sharing my screen, what the experience really looks like. As a user, you come into our app or web-based platform, we ask questions, and we recommend that there is certain specific solutions that make sense to you. And for example, in this particular case, I was experiencing anxiety and the severity came out as moderate. The recommended solution for me is coaching. So from a user's perspective, we narrow down the choices that make sense based on what they're experiencing so that we can take people to the right kind of care. So people who are on the lower end of the spectrum are taken to more of our CBT-based self-use programs. Vast majority of users really fall in that moderate severity part, where we take them to our asynchronous behavioral health coaching. And people who are on the higher end of the spectrum, that is where we take them to traditional forms of care, which is therapy, in-person or video therapy, and in some cases also provide them behavioral health coaching option. But the whole aim is that instead of taking every end user to the same exact solution, we look at the risk, look at the type and severity of the problem, and optimize the overall care for that individual user. And this was the experience from the user's perspective. But if you look under the hood, what wayForward really is focused on is optimizing the delivery of behavioral health. So what we really focus on is the technology-based aspects of care, which allow individuals to identify what they're experiencing, and we deliver the self-guided and the behavioral health coaching. We're not providing, and I want to be very clear on this, that we are not providing end-to-end full stack care where we provide video therapy, in-person therapy, because we believe if we are providing all of that, our incentive is to drive end user to the highest cost care. In this model, our incentive is to make sure people are being taken to clinically relevant care so that we are optimizing the overall cost. We are making sure only those who really need the higher form of care, like therapy, in-person therapy, or psychiatry, they get that access. So we have rolled out this model. The way we really go out to market is we are going out via various partners to employers mostly. We have rolled out to over 90 employers via traditional mental health companies, via health plans like Humana, and in some cases directly to employers. And we're increasingly starting to work more with health plans. And our product overlays on top of your existing provider network and provider solution. So for example, we work with a number of existing teletherapy companies who are already in network with health plans. And the whole point of our solution is that we make the networks more efficient. We make sure people who are on the low to moderate side severity, they are being taken to more digitally driven care. So that's how our overall product really works. And from a user's perspective, the experience really is, it's a text-based and a voice-based coaching model that utilizes cognitive behavioral therapy. We have over 20 cognitive behavioral therapy programs that have been developed in-house by our team. And once you reach a coach, the coach is assigned to you within 60 seconds. So it's a very, very quick assignment to a coach, and the coach respond to you almost immediately. And there's a back and forth. The coaches have an 8-week time-bound evidence-based protocol where coaches are sending specific content, CBT-based content, specific assessments, specific programs to you. And it is all focused on getting you better in terms of managing your anxiety level, looking at your, for example, PHQ-9, GAD-7 scores, or the overall assessment for subclinical conditions like stress or relationship problems, and showing overall improvement. So just in the interest of time, I will talk briefly about how our results and how we look at our results overall. So traditional employer-focused solutions tend to have 2 to 3% utilization EAPs. We tend to get approximately 17% utilization, and through COVID, that utilization level has gone over 20%. But it's not only about getting more people in the funnel and screening them and taking them to these digital modes of care. We also see 48% reduction in anxiety symptoms, 59% reduction in depression symptoms. And this is based on a study that was conducted by University of North Carolina. And we're also measuring organizational outcomes. So these are third-party validated assessments that show outcomes in terms of the impact on productivity, impact on absenteeism, that are important for the employer market. And
let's pause there.
okay.
Move to our judges panel.
Excellent. First of all, very good, exciting. Question in how do you ensure that the patient really needs to have a digital therapy and they are not, you're not putting them in danger, anything from a suicidal thoughts or any more serious condition? How do you ensure that?
That's a great question. So we do have a screening for suicidal ideation. And so if you, when we do that, the initial assessment, there is always a screening for suicidal ideation. In addition to that, when you are assigned a coach, coaches are always trained in clinical protocols. So if someone has suicidal ideation, there is a way for coaches to escalate that person. So if they need to be stepped up and connected for in-person therapy or teletherapy or need crisis help, there are clinical protocols. So it's not just making sure that they get digital care, they can always be sent to that. And also as step down care. So if you've gone through 8 weeks of therapy and your conditions are less severe, you can be stepped down to coaching. So both of those models exist, and crisis management is always a critical part of what we do.
Thank you.
Thank
Okay.
you.
Clement, did you have a follow-on?
No, that's it. Thank you.
Great. Okay. Let's turn to Bill. Bill, do you have any questions?
Yeah, the question I had, the 17% engagement is really impressive, and I'm curious to know what you're using in terms of either predictive models and/or outreach to drive that level of engagement.
Yeah, Bill, that's a great question. So we have a pretty comprehensive sort of engagement strategy, which really looks at multiple ways of engaging the end user. First of all, I would go, what our solution really focuses on is not just severe conditions, but also if you have subclinical, you might be feeling stress or you might be having sleep-related problems or relationship-related problems. So we have email campaigns that we provide to all of our partners that can be white labeled and they send out. We have a whole set of, for the whole year, different kinds of flyers. We do different sort of right now digital, but earlier there were some in-person events. We do single sign-on integrations into existing platforms. For example, employers might already have a wellness or a vendor or platform. So there are a lot of different ways that we open these doorways through which individual members or employees discover wayForward and find out that they might need help with not just anxiety or depression, but certain subclinical conditions as well.
Terrific. I think we have one more time for one more question, a short one from Steve.
Great. I'll try to ask a short question then. Interested in the ability to scale. Question was asked in the prior presentation, which is a good one. Obviously digital, the coaching availability. And again, I wasn't sure if they were employed or they were contracted. And what is your ability to scale to a company the size of either Anthem or ACSC?
That's a great question. So one of the key questions, till about earlier this year, we were mostly focused on the employer market. And as we started going to more health plans, we got Martha Temple and the founder of Able2, Michael Askoff, on our board. And we very consciously decided on keeping coaching in-house because for therapy, you have to get licensed clinicians in all states. So coaching can be done across state lines. Coaching can go masters and sometimes below masters level, as long as they are trained in these CBT-based protocols. And the other thing for our coaching tends to be that it is technology enabled. So you're actually talking to a human being, but there is an AI assistant to the coach that is constantly providing suggestions that allow the coach to send specific content or specific text to their clients so that they can handle more clients. So that is why our focus has remained on this clinical technology aspect. We have all of these as contractors. So that's why we're focused on something that more technology driven and can be scaled rather than the networks part of it.
Thank you very much. My name is Dr. Mohsen Omrani. I'm the CEO of OPT, the online psychotherapy tool. Pandemic has just deepened the rift between supply and demand in mental health care, and with the prevalence of mental health problems at this time, we simply do not have enough clinicians to deliver traditional live face-to-face care to patients. While it is not possible in the short term to increase the number of clinicians, we could make sure that the clinician's time is efficiently spent, and that is exactly what we do. Using a digital-first hybrid model, we help healthcare organizations increase their care capacity and optimize efficiency by more than 5 times. OPT is a well-rounded solution which is easy to deploy, scalable, and patient-centric. Our solution could be deployed in a white label, a standalone model, or API-based for existing apps and platforms for healthcare organizations as hospital, telemedicine companies, or payers. We have various onboarding options, like as easy as sending out a link to bring up healthcare providers and patients on the platform and connecting them to each other. And the form of interaction between them is a structured AI assistant asynchronous care. So how it works is that we have developed clinically validated, pre-designed disease-specific modules that the clinician assign to their patients. Patients go through the content on their own time. At the end of each session, there is a homework that they submit, and the clinicians only provide personalized feedback on the homework and skip repeating the same general concepts for different patients. This way, they can handle each patient within 10 to 15 minutes as opposed to traditional 1 hour. At the same time, we are continuously collecting more than 20 different clinical, behavioral, and physiological benchmarks and provide analytical reports about patients' progress and outcome predictions based on which clinicians could continue the course of therapy or adjust it, like adding medication or video face-to-face. In addition to our therapeutic content, our AI algorithm, proprietary AI assistant, supplement our solution to optimize delivery of care and improve care outcome. For instance, one of the features we just released is called automatic labeling. Our algorithm goes through the patient's homework and automatically highlights the most sensitive and symptom-related sentences in the patient's homework. And each session comes with session-specific feedback templates that part of them are static. They don't really need to be changed across patients. But for the dynamic part, we provide training on how to use the highlighted material to develop, devise the response. And within the next 6 to 12 months, we are hoping to release, the first, so our algorithm can provide the first draft, so the clinicians can just tweak and do their job faster. We have some other solutions for remote mental status evaluation and outcome prediction that I can talk about later. Well, does it work? Well, our clinical solutions and therapeutic content has been validated across 8 clinical trials. We have up to 90% completion rate, and on average, patients complete 8 sessions, which is twice as many sessions as compared to the other self-guided CBT material. We have 25% to 45% symptom reduction in a range of diseases from depression to anxiety and personality disorders. And we actually ran our COVID-19 clinical trial over the last few months, showing that our modules can decrease the anxiety by 25% and increase the quality of life by 15%. And based on our expertise, our chief medical officer and myself have been commissioned by Springer Nature to write the first handbook on how to deliver online CBT. So we have literally written the book on this. So organizations using our standardized material and solutions and validated solutions, organizations can use lower cost personnel like social workers to deliver the bulk of the care, as opposed to, for instance, psychologists, which there is 4 to 5 times saving right there. And instead of handling 7 to 8 patients a day, they can handle around 25 to 30 patients. And one round of therapy, which usually costs around $3,000, now could be delivered as cheap as $300. That means that patients have access to accessible, affordable, effective care. Providers can increase their care capacity and their revenue, and payers can save costs and increase their margin, also saving on the long-term cost. But our biggest asset in our company is our team of experts. We are not a team of engineers who wanted to do something. This was clinic first, and we added an adept team of developers and advisors like Ewan Amigi and Dogu Chalebi, who are veteran in healthcare implementation. They have been working in United Group and Optum, who are helping us expand our reach in the US market. So we have prominent customers like Queen's University or EQ Care, which is the second largest Canadian telemedicine company, giving us access to 500,000 of their users. We firmly believe that mental health problems are chronic disease problems, and we are hoping that based on building upon our strong clinical and AI infrastructure, we can promote continuity of care. We have 5 or 6 different clinically validated modules. We have a bunch of modules in the pipeline, and using the remote monitoring, we are hoping that the continuity of care would be possible. We strongly believe that OPT is the future of mental health care, and we hope you join us so we can change that together. Thank you.
That was a great quick overview. Appreciate that. You have a lot of things going on there. So I actually had 2 questions. One you kind of partially answered. I was wondering in which areas you all have seen or been the most impactful, based on, again, the different modules that you have certified against or you've qualified against. So that's the first question.
So for instance, we had a really good outcome from our personality disorders, for instance, or we had done a clinical trial for adolescents' anxiety, and interestingly, the online group was significantly better outcome than the live group. So the outcome for and the adolescent anxiety was amazing, but as I said, there is 25% to 45%. It all depends on different groups, but generally, probably anxiety would be the one that has the biggest effect.
Mm-hmm. And then with your AI models, how are you all going about, developing your corpus or training, your corpus? What approach do you use for that?
So we have a deep learning network. At this point, we are using natural language processing that we are tuning to our data. So we have data sets that are, very rigidly labeled, so we know that, for instance, this homework belongs to session 1, this homework belongs to session 3. This is the, PHQ-9 GAT-7 score of patients in this session. This is the outcome in that session. And we have the clinician's feedback, and all those things go into this model of predicting what we can do next. And everything is, goes hand in hand with the modules. So we know what is discussed and what we can do. And one of the things that, for instance, we have been able to do was that, for instance, using the first 2 sessions of patients' homework, we can predict by 70% accuracy patient dropout 3.5 weeks in advance of them dropping out. And for instance, our next clinical trial would be to give that information back to the clinician and ask them, okay, we know that this patient is probably dropping out. You might want to add medication right now, or you might want to add, video face-to-face right now.
Yep, that's great. Thank you so much.
Thank you.
Great. We'll turn our next question to Steve.
Yeah, great. Thank you. So toward that end, do you have, I guess, two-phase question here. Do you have, are the social workers, coaches, are they currently contracted or are they employed?
We are not providing the care ourselves. We are implementing the solutions into existing healthcare organizations. Like, for instance, if there is a hospital, they have their own patients, they have their own care providers. Now they can, connect them like this and provide a more efficient solution. So, in a payer system that they have their own providers. So we don't want to get involved with this. That is the key for scalability and data, kind of able being to collect major data.
And maybe the second part then to give you just a little bit of opportunity to explain your current customer base.
Yeah, so as I mentioned, we are a Canadian company, and we are basically, our major contract is in a second largest telemedicine company in Canada called EQ Care. They have 500,000 users. They have contract with, organizations like Walmart and Bell Canada, and they are running, presenting their mental health, product completely backed on our solution. And we are naturally, fairly young. We are hoping that we can expand our solution rapidly in the US market.
Great, thank you.
And last, I'm going to go to Plumman to ask hopefully a short question on this one.
Sure. Have you experienced any issues as you're offering a white labeled solution to different providers or payers, and that can become a fairly complicated integration activity? Have you? What is your experience with that?
Well, the white label solution is not that hard. We can do it usually in 2 weeks and get up and running. The more challenging and time-consuming one would be the API integration. That we have our standard APIs that organization could call our modules or call our prediction models and everything. But we didn't have, for instance, in the last 2-3 months, we actually implemented 3 different organizations, as I said, within like 2 weeks. So it's not that complicated.
Hi, everyone. I'm Mary Beth Basu with Peck Health. I'm pleased to share a little bit more with you today. So it's no secret that the COVID pandemic has demonstrated a real need for innovative solutions to address behavioral health. We've heard about the challenges during the pandemic directly from our members. They report the pandemic making it harder to eat right, get their medications, be social and active. Overall, it's increased their stress and made it hard for them to do the things they know they should be doing to manage their health. People are overwhelmed, and Peck Health changes that one person at a time. So it's clear that Americans are suffering from increased stress, depression, and anxiety as a result of the pandemic. And we know that costs related to these conditions are high. Those with behavioral health conditions cost more than $800 more per member per month. We also know that these behavioral health issues often coexist with chronic conditions. In fact, those with behavioral health issues are 40% more likely to get heart disease and diabetes. And those rising risk folks are who we work best with. And there's a lot of digital health solutions out there, from telehealth visits to AI-powered chatbots. So how are we any different? We believe that you can't silo out behavioral health issues from overall health. To really move the needle, you have to understand the context of a member's daily life and what gets in their way. We complement clinical care by connecting with members 5 times a week to understand their goals and, more importantly, their barriers, and then to deliver last mile coordination services that are critical to help members be successful at home. Anything from transportation assistance to food and medication delivery. And so our program was built on these 4 foundations. The first is to be comprehensive, understanding that behavioral health is likely not the only issue going on with a member. The second is to be high touch, yet efficient and simple to engage. For that reason, we use a dedicated coach as the hub of our program rather than a website or an app. And that brings me to our third foundation. We really believe that education alone doesn't change behavior. That's why we focus in on an individual's barriers and respond by using a configurable open API tech stack to deliver just those relevant resources and coordinations to address those barriers. And fourth is to always deliver an approach that's grounded in evidence. So how do we get to the root of what a member really needs? It begins even prior to enrollment. Typically, our health plan partners identify good candidates for the program based on diagnosis history and risk scores. After the member enrolls in the program, they meet their dedicated health advisor who they work with through the entire engagement. That health advisor helps them connect any health monitoring devices they may have to the platform. And then they are off on a cadence of goal setting. So first we understand what the member wants to accomplish with us over several months. And then we follow up throughout the week with texts and emails. We do a couple things with those nudges. First, we can collect data, not only from the member's health monitoring devices, but also using patient-reported outcome sets like the PHQ and the GAD-7, the UCLA loneliness scale. As we're interacting with members and asking about how their goal is going this week, we can also understand what barriers they're running into. And this helps us to deliver tailored education, accountability, reminders, or connection to other resources. The resources that we offer members really fall into 3 categories. The first is resources we create in-house, like our educational content, meal and exercise plans. The second category is partnerships that we've secured with organizations like Aunt Bertha for local resources, Uber Health for transportation needs, Walmart for grocery delivery. And then the third category is care coordination, care escalations, either back to the provider on record or back to health plan resources like case management. And it's our Salesforce operating system that allows us to really hold all these capabilities, but only offer up to the member what they need. So the platform receives data from our member calls, health devices, surveys, partner info sources. And based on what's going on with the member that week, the system serves up to our health advisors the services, content, and messages that the member would benefit from at that time. Now, members don't see any of this technology. It's really on the back end to keep the user experience simple. Like what you see in this screenshot, we deliver these resources through text and email. So this platform gives us great breadth and depth without overwhelming the member, and it's very flexible to meet our different plan partners' needs. So to give you a few examples, Blue Cross Blue Shield of Alabama uses us in the commercial segment. We serve about 20 of their self-funded employers. We've demonstrated nearly a 5-to-1 ROI. And we bill through claims in the segment, which the employers really appreciate. Humana uses us in their Medicare Advantage and their commercial segments. About 82% of these members have 2 or more chronic conditions, and 20% also have a behavioral health issue. Humana realized earlier this year that members with both were incurring significantly higher costs. So we launched a few months ago, and we've had success engaging their members, particularly with texting. People really prefer direct communication with their coach over having to use an app or a web portal. And then finally, United uses us in their DSNP segment, realizing early in the pandemic that food insecurity was worsening in this segment. United sought a partner that could rapidly scale for condition-specific grocery delivery to their most vulnerable members. And we've now coupled our high-touch coaching approach with grocery delivery through Walmart, and we've delivered over 1 million meals this year. Blue of North Carolina is also using this solution. So as you can see across different segments, our program is effective and it's flexible for each of our different partners' needs during the pandemic. I'll close by sharing some of our results. We collect about 150 data points on each member every 12 weeks, so we show results relatively quickly. You can see that we improve behaviors like medication adherence, utilization metrics, health improvements like A1C, as well as mental health indicators like depression and financial stress. We've completed a myriad of studies on the effectiveness of our solution in different populations.
In time.
Great, super helpful. On the one of my questions, results are super impressive, but if you looked at the percent of population engaged, how are you guys doing just in terms of engagement? And maybe a little bit on tactics and things that you do. You mentioned referrals, but are you guys doing outreach on your own as well or anything like that?
Yeah, it varies a little bit by segment. So we work not only directly with health plans, but with employers directly. We have relationships in the pharmaceutical industry, as well as with health systems and nonprofits. If we're looking at the health plan employer space, our typical enrollment is about 5% of the total population. If you think about, the segment that has chronic diseases, we're quite impactful at engaging those. Once people engage in our program, we have about a 57% retention rate and a 75% completion rate. So people who do enroll stick with the program real well. In terms of how we engage members, we use a combination of email marketing, mailers, digital posts, retargeting ads, a variety of strategies depending on the member segment.
Mm-hmm. Cool, thank you.
With that, I'm going to go to Plummen on this next one.
Great, thank you. Question, do you have any measured feedback from your users, like any scores of how usable they find and how engaged they are?
Yeah, we use NPS as one way to measure engagement. We average about a 60 NPS, which is quite high. And then we do a good bit of feedback as well from members directly, so they can talk to their health advisor about feedback for the program. We have an online option for them to submit feedback. And we also ask that NPS evaluation at various points throughout the program to ensure their satisfaction early, midway through, and then later in the engagement as well.
Excellent, thank you for that one. Steve, let's go to you and see what questions you may have.
Yeah, great presentation. Can you talk a little bit about the health advisor qualifications and how, if there's it's kind of a scalable way to address some of the higher risk patients to those with higher qualifications?
Yeah, that's a great question, Steve. All of our coaches are in-house. We hire from a variety of allied health backgrounds, and when they come on as employees, we put them through the National Board Certification for Health and Wellness Coach. We're actually a training site for that program, so we train not only our own coaches, but coaches for the industry at large. And so since they are non-clinical in nature, when we do identify a care escalation that's needed or a clinical need, there's a couple different ways that we can route those. We do collect from the member information on their providers. So within our system, we've stored the provider's name and their contact information so that we can escalate issues back. And then Salesforce allows us to customize our escalations by client. So for our different health plan partners, we can program specifically for their members referrals to perhaps behavioral case management teams, in-network provider finder tools, or their internal nurse teams to triage those more acute needs. But we find that the bulk of the issues that members bring to us are non-clinical in nature. It's not that they don't understand what their doctors ask them to do, it's that they can't do it on their own. They lack those resources and the path forward and the person to motivate them along the way. So we find that the grand majority of the members that we coach, their needs can be met by the health advisor in our collection of resources, but we do appreciate having those care escalation protocols in place.
Great, thank you.
Well, thanks everybody for inviting us here today. We're really excited to talk about how WiserCare and Anthem's data set can help to advance chronic disease management during this pandemic that we're in. So first off, what is WiserCare? WiserCare is a set of clinical software programs that support highly personalized evidence-based care at scale. The way that we do this is by using an evidence-based proprietary preference assessment and decision modeling platform that's built on a platform that is really built to scale. We are able to, over the lifetime of WiserCare, we've shown better clinical outcomes, higher member and provider satisfaction, as well as lower overall costs of care. So how does WiserCare work? Upon member identification, WiserCare gives members an experience that is tailor-made to the chronic disease management decision that they are struggling with. We identify members using care team assignments or population-based care gap measurements to enroll them in our program, which takes into account their clinical factors and their preferences, combines them with the clinical data to give end users like physicians or telemedicine providers or case managers at plans the tools they need to help manage that patient's chronic disease. WiserCare is evidence-based. We have over 40 articles and podium presentations based on our work. We've been around now for about 6 years in a commercial space, and we have a variety of large health system and plan customers across the country. Over 10,000 patients have used WiserCare's decision support algorithms, and we have in our leadership team over 100 years of healthcare technology experience. Each person on our leadership team has been in this field for over a decade. But on to why we're here today. So the COVID-19 pandemic dramatically changed the healthcare landscape in a lot of ways, but specifically in preventative care and chronic disease management. I know as a primary care doctor myself that my high-risk patients in the world of COVID had the resources they needed, even as care got dialed back for my low-risk patients. My high-risk patients had care managers. They had other folks looking after them to make sure they got the care they needed, even as the access to care during the COVID pandemic became dramatically lower. But my low-risk patients had no one looking after them. These low-risk patients were folks with newly diagnosed diabetes, newly diagnosed hypertension, who simply were left out in the wind as we refocused our care mechanisms on other issues. And why did we leave these lower risk patients behind? There were some good reasons. As providers, we had new responsibilities. We were focused on the pandemic. We had less time to devote to panel management. Usual care patterns were disrupted. We're really focused on delivering in-person care, and obviously COVID-19 changed that quite a bit. But more so, member and patient identification became very difficult during the pandemic. We had no reliable way of measuring or tracking these low-risk patients before the pandemic, and there was no reason to think that we could do it during the pandemic. It was just a hard problem to solve. WiserCare was built to address the problem of managing patients with not enough time. We actually have shown lower time utilization during visits when WiserCare is used by the patient and the provider. And we're also built to be a virtual asynchronous platform, which makes us easy to use as usual care patterns were disrupted. But this member and patient identification piece is a particularly hard problem, especially during the pandemic. WiserCare can drive value in chronic disease management, and we've shown this over the years. We have an omni-channel engagement approach that results in a very impactful member experience. We have between 20 to 90% engagement of members, depending upon the channel that they come in through, and a very high engagement to completion ratio. Ultimately, we drive lower utilization, higher satisfaction, and higher decision quality, which ultimately to the plan accrues value primarily in lowering overall cost of care and increasing member loyalty. In this particular project, what we propose to do is uncover the markers and those populations in the Anthem data set that may have benefited from a tool like WiserCare at the beginning of the pandemic. We know that there are hidden low-risk members and members who needed care optimization who simply fell off the care map. We think that there are sandbox elements, including basic member data and discontinuity of care indicators, that we can combine with our WiserCare algorithms to first identify those members who could have used an intervention, and then actually simulate that intervention to see what the actual outcome might have been. We can actually prove in this scenario the ROI of taking care of our low-risk patients at the beginning of the pandemic and not just our high-risk patients. If we're able to do this well, the impact could be huge. We know that half of US adults have simply avoided going to see a clinician because of COVID-19. A quarter of US adults have reported worse health outcomes because they haven't seen a clinician. And there are about 11 million Anthem and HCSC members with chronic disease who have delayed care during COVID. We clearly need to reach these members. WiserCare is uniquely positioned to tackle the problem of re-engaging these low-risk members into care. We have seasoned healthcare technologists who can analyze these large data sets. We have proprietary algorithms that have importantly already been vetted through in commercial use with our other large health system and payer customers. We believe that Anthem has a unique opportunity today to partner with WiserCare in affecting not future pandemic responses, but the pandemic response that we're in today. We know that this COVID-19 pandemic happens in ebbs and flows. We're currently in a flow, and I believe that today is the day to find these low-risk members and re-engage them into care. If we're able to do so, we can save dramatically on lower downstream costs once the pandemic ends.
I'll just ask my same question. You mentioned the engagement rates. What kind of engagement tools do you use, and what explains you mentioned the channels. If you imagine what you've proposed here and leveraging the sandbox to identify those disengaged, how would you think about engaging those folks?
Yeah, we usually use 3 engagement approaches here. And let me just get back here. So we have a physician practice engagement approach that we've used with payers like Blue Shield of California, where we actually work with the plan to deploy directly at the physician practices. That usually results in very strong engagement, between 70 to 90% initial engagement with very high completion rates afterwards. We also have low touch approaches like a member self-serve approach that can be put onto any care manager or any member platform or a patient portal that usually results in slightly lower engagement rates, around 20% engagement, but still with very high completion. So we usually suggest to our plan clients a mix of these 3 engagement approaches. The care management approach, or the plan-based case management approach, is around the middle. It's about 50% initial engagement with 90% of those members following through to completion. A mix of those approaches yields a mixed average of around 40 to 60% of engagement, and then 90% of those go to completion.
Excellent. I'm going to have Plamen ask the next question here.
Thank you. Very exciting. I liked a lot what I saw. Question: you mentioned briefly that you've measured and can demonstrate ROI. Can you speak a little bit more about it? How do you measure the ROI, and where does it come from?
Right. Our ROI calculations usually come from a variety of downstream indicators that are specific to the programs that we're putting out there. So I'll give you an example that's slightly related to this in spinal disc herniation. Our spinal disc herniation programs reduce overall utilization of surgery by about 30%, which leads to a direct ROI calculation over a population. We have another application through advanced care planning that reduces overall cost of care in the last 1 to 2 years of life by about $10,000. And clearly that ROI calculation is different based upon the member segment that we're tackling and the type of product that you have with the plan. The MA population is very different than the commercial population. But usually we use a variety of leading indicators combined with our demonstrated outcomes on the clinical side to combine this data and ultimately provide an ROI for the specific programs that your plan is buying. Diabetes, hypertension, hyperlipidemia look different than some of our orthopedic applications or advanced care planning applications.
Excellent. Thank you for that answer. I'm going to go to the last question to Steve.
Great, thanks. Very impressive and very a lot of opportunity and application, certainly for ACSC here. Can you talk a little bit? So you got a sense for on the payer side. How are you've got a number of hospital system clients there. Can you talk a little bit about your engagement with them and how they've kind of leveraged what you have and some of the outcomes that you've seen from them?
Yeah, sure. So WiserCare actually started on the provider side. It's only fairly recently in our company's history, over the last couple of years, that we've gotten really involved on the payer side. So we started on the provider side because we were born out of UCLA. Our co-founder is the vice chair of urology there, and a lot of his foundational research led to the algorithms that we still deploy to this day in WiserCare. Our health system clients use WiserCare in a bit more of I'd say just fewer fragments in the process. We are usually integrated into the EMR. We can directly pull data from the EMR to enroll patients. We have a tighter loop back to the physician. So that makes it quite easy. Working with health plans over the last couple of years, we've had to modify this approach and come up with different engagement solutions, but also different delivery devices. So we've invested pretty heavily in replicating that health system experience on the plan side whenever we can.
Any crossover between the two?
We're still looking for that, actually. We haven't had a direct crossover, but there's a couple things in play at the end of this year and the beginning of next year, primarily in California, that we think might be really unique opportunities for payer-provider collaboration.
Are those more on the risk-based contracts, or are they more on the fee-for-service?
Yeah, they're more on the risk-based contract. So Blue Shield of California has a primary care reimagined program that they're rolling out, similar to the Blues in Massachusetts and North Carolina, aiming to support independent practices and converting to risk-based contracting. Shared decision-making using WiserCare is one of the key initiatives that they'll be pushing out to provider groups beginning in July of next year.
Great. Thank you.
Sure.
Hi, everyone. My name is Sean Glenn. I'm the Director of Health Economics for Health Beacon. Health Beacon has developed the world's first smart sharps pen. We're here to help patients who are on self-administered injectable medications for chronic conditions to stay on track with their prescription. Earlier this year, the thousands of Health Beacons which patients are already using started telling us that patient medication taking behavior was shifting. As we dug into this, we heard a couple of things that suggested COVID-19 was playing a role. Some patients were wondering if taking their medication would compromise their immune system. Others were wondering if any global disruptions in the supply chain would delay their medication, and should they be spreading out their dosing. These issues, unfortunately, were compounding the pre-existing non-adherence problem, which is already costing the US healthcare system over $300 billion a year. We're hoping to work with Blue Cross Blue Shield of Illinois and Anthem to quantify the impact of improving medication adherence for this vulnerable population, while simultaneously driving down healthcare utilization and claims costs. The Health Beacon is HIPAA compliant and FDA cleared in the US and NHS approved in the UK. We're currently in 15 different global markets, with 5 more launching before the year is over. Our technology has been deployed to over 10,000 patients and has tracked almost 500,000 injections to date. We have implementations with half of the world's largest pharmaceutical companies, and all of this is a long way of saying that we've been strenuously vetted and tested. What we do not have yet is a partner in the US health insurance and managed care space. Let me show you how the Health Beacon works. You can see here the Health Beacon product family. Information on the LED screen tells the patient their personal adherence score and the date of their next injection. The Health Beacon's elegant exterior houses a traditional sharps container. When the patient is due to take their medication, the Health Beacon will light up and the patient will receive a text message reminder. As they dispose of the used syringe into the Health Beacon, we capture an image, timestamp it, send it to the cloud, and reconcile it with the patient's treatment schedule. Our new app puts data and services in the hands of the patient. From here, they'll receive alerts and can check their adherence score or review a log of past doses, which they can share with their healthcare provider. It's also worth mentioning what happens when we do not see the image come in according to that patient's customized dosing schedule. A series of escalating interventions kicks in to help the patient get back on track. What appears to be an elegant, simple, and passive system to the patient is backed with a robust methodology, advanced analytics, IBM Watson image recognition technology, and a staff including medical doctors and data scientists. A study we conducted in Ireland, which is Health Beacon's home base, demonstrated a 31% impact in patient persistence to medication using the Health Beacon system. Last year, we conducted a post hoc analysis of a previously published study to model the impact of the Health Beacon to see what impact it would have on healthcare utilization and claims costs for patients with inflammatory bowel disease and Crohn's. And we found a modest impact driving down emergency room visits and a double-digit reduction in inpatient hospitalizations. These reductions pointed towards a savings of $1,417 per member in the first year. For as robust as our model is, it's based on someone else's data, which we had no control over, which is why we were so excited to enter this challenge to get access to the digital data sandbox. We'd like to demonstrate the improvement that we can collectively make in patients' lives while lowering the burden on the healthcare system and driving down claims costs. providing remote smart tools which will enable patients to stay on track with medication, while alerting caregivers to those patients who are most in need, we believe is a fantastic response to this pandemic. What we need is access to data to validate our model. The project that we'd like to work with you on is to look at the impact that COVID-19 has had on adherence to biologics. Specifically, we're interested in high consequence conditions such as IBD, Crohn's, and moderate to severe asthma. And we'd like to look at a data set where we could filter by disease code and national drug code and use prescription fill date to calculate the medication possession ratio. We'd like to look at the influence that varying levels of adherence has on variables such as admit date, discharge date, billed service unit count, and billed charge amount. And we'd like to put the Health Beacon in the hands of Blue Cross Blue Shield of Illinois and Anthem patients and look at how the Health Beacon changes adherence patterns and the resulting health outcomes impact. The result being is to develop a very specific and customized model for the health insurance industry. We believe that this project is a great fit with the stated purpose of the Digital Data Sandbox for projects that seek innovative solutions to the complex issues of healthcare. Thank you.
Sean, that was great. I do like IoT type stuff, so it's a great thing to see this in action. I guess you know, one of the questions that I would have is, again, so most of the information that you've been able to look at has been, I would call it on health systems that maybe are not like the US health system. And so I guess what are your thoughts with regards to, how this is going to work, for instance, with the administration and, some of the other, I'll call it opportunities that, we talk about every day, with our multi-trillion-dollar environment that we're dealing with.
Yeah, so we have launched with clients here in the U.S., some of them very large scale, but we feel confident that we're ready to integrate with large scale payers such as yourselves.
Okay. And what would be, just a follow-on question to that, what would be kind of the ramp approach for that? What would you suggest would be kind of maybe our journey?
Yeah, so kind of what we were looking for with this project was to dig into the data sandbox and to interrogate that data, look at the impact, look at the adherence rates for biologics for patients on the conditions that I mentioned, put the Health Beacon in a number of patients' hands and be able to look at the prescription refill date, medication possession ratio versus the better measured adherence using the Health Beacon, that medication event monitoring system, to really kind of track and see and model the impact for the health insurance industry.
Mm-hmm. Okay, thanks.
Excellent. From that, I'd like to turn it to Plamen.
Great, thank you. Have you thought through the, so my question is kind of broadly around the economics, managing and maintaining, this is hardware, there's technology here.
Mm-hmm.
Have you thought about like a large scale distribution, let's say in the US in a large plan? How do you achieve that?
Yeah, so like I said, we have, and as we're scaling up in the U.S. with a U.S. client right now, that would probably take us to 30,000 units in the U.S. quite quickly.
And you have all the supporting like infrastructure fixes, replacements, things like that, and.
We do everything, even down to the distribution of the unit, how we get the unit back, how the unit is cleaned and sterilized, put back into circulation, et cetera.
Great.
Excellent. Let's go to Bill for our last question.
So my question is sort of how do you integrate back with payer or providers, and so what's your strategy for engaging providers in this process?
Yeah, so our strategy for engaging the provider is to, we want to kind of take some of that work away from the provider initially to enable, kind of the health beacon and its automated system to get the patient, to improve adherence with those systems. However, we do know that some patients are going to need, another level of support, a little outreach by a human. And so, we're kind of prepared to do that in two different ways. One is our in-house team, that can get escalated to them and they will do outreach to the patient. And in some cases, what we do is we work with the client organization and their staff to do that outreach to the patient.
And maybe just a really quick one, just based on your back of the envelope, how many people do you think we would be touching with? I mean, if you put this in place at a 5 million member plan, how many people do you think you'd touch? Or what's the size of the prize, I guess?
Yeah, I think it's in the kind of hundreds of thousands, depending on looking at, starting with, some of those real high cost, high consequence medications and conditions, that as someone asked earlier, kind of what the ramp up would be, that would be kind of where we would start, but I would say that it's hundreds of thousands.
Got it, thank you.
All right, thanks. Excited to be here. And I'm John Bloom. I'm a physician and the CEO of Podimetrics. We're a virtual care management company for the elimination of diabetic amputations. The diabetic foot in general is probably one of the most expensive problems that the healthcare system often isn't aware that they have. It can be as much as a third of the cost of diabetes. And the reason why it's been here for so long and been tough to work on is there's about 200 codes that sum up to make diabetic foot ulcers. And it's difficult to manage, which you can't measure effectively. We estimate that from a number of payers now that the cost of a patient who has a diabetic foot ulcer is about $60,000 per member per year. And that patient has, unfortunately, about a coin flip to get another diabetic foot ulcer in the 12 months to follow. Across the two sponsor plans, we estimate there are about 90,000 members who get a foot ulcer each year, contributing to $4 billion in direct expenditures every single year. COVID-19 has really exacerbated this problem. This is a patient, the one who gets diabetic foot ulcers, has multiple comorbidities, heart failure, bad kidneys, bad lungs. It's a very complex patient. And this patient is reliant on preventative care. Right now, our preventative clinics are at limited throughput. And this patient is the exact same patient at risk for COVID-19 and is worried about leaving the house. And as a result, we've seen now a paper in Diabetes Care that diabetic amputations are up threefold compared to the same period last year. It's a patient who struggles with access already, and now they have very limited capabilities to do so, and they're living in and out of the ER in the hospital as a result. The real problem we had to solve wasn't necessarily prediction prevention of foot ulcers, it was one of engagement. How do we get this patient to choose to use the system every single day for very long periods of time to get the outcomes we do? What we design is a mat that goes into the patient's home. It looks like this. If we get time later, if you guys be curious, I'd be delighted to show you a demo. We have them just step on it for 20 seconds a day and go on with the rest of their life. There is zero setup. There's no Wi-Fi, no Bluetooth, or no smartphone required. It's good to go. And we wrap around that a nursing layer that if we see any problems, we can reach out to them and coach them through it before the actual problem presents. A couple quick stats though. The science we use to predict and prevent foot ulcers, thermometry, goes back to the 1970s. It's now backed by a number of randomized control trials funded by the NIH. It's in all the clinical practice guidelines. It is very much considered standard of care, and yet we don't see it anywhere because of this problem of previous systems being very difficult to use and have poor adoption. It actually takes us a very short period of time to get up and running with a pair, about 90 days, and we can be up and running. And the savings you'll see, the ROI will actually hit often within 3 months, usually 6 months, and certainly within a year. So it has to do with getting the right risk profile when you onboard patients. To support that, we actually see about, with one of the national Medicare Advantage payers, an estimate their estimate is roughly $12,000 of savings per patient per year when applying these data that we see I'm about to show you. So Kaiser Permanente reached their published their results about 2-3 weeks ago, so this is fairly new. We saw a 71% reduction in amputations, a complete elimination of all major amputations. No one should have to lose a limb to diabetes. We saw a 40% reduction in ED visits, a 52% reduction in all-cause hospitalization, and a 27% reduction in outpatient visits. This is a very complex patient. Just to give you a sense, over half of them had already had a partial foot amputation before we got them. Behind that, though, is this data science layer. And to give you an intuition how it works, we see about 1.5 hotspots per patient per year. So it's a very rare alert. 2/3, 68% of them, we can telephonically eliminate with good coaching. We can talk more about that if you're curious. And are the ones we have to escalate to the clinician. 76% of them have something that has to get done urgently by that clinician, but it's almost always callus that needs to be debrided. You debride the callus, that the area that's causing pressure and destruction of tissue that tends to end the entire cycle downstream. What sets us apart, a couple of things. First of all, is we only roll out to the most highest risk patients. This one who's typically has a lot of challenges with access. That gives us a very high ROI in excess of 3x return and about $12,000 in estimated savings per patient per year. Second is very simple, but if you focus on prevention rather than treatment, things we can do with plans like Anthem, we can save a ton of money just by that small shift. We spend easily 10x on treatment as we do prevention. A lot of this biologics, et cetera, is all completely unnecessary. Just in terms of engagement, some stats. Our net promoter is 74, fairly high for a healthcare company. We see 86% adherence per a diabetes care article we had a couple of years ago. And surveyed 88% of our patients said it was 5 out of 5 easy to use. This is a very simple system where you just step on it and go. As far as this, what's so exciting about this implementation here is that we know that because of COVID-19, these patients are really, really hurting far more than they would have normally, as suggested by that diabetes care article. Or there's probably a number of things that are driving that. And we're also looking at better ways to identify that patient. What we propose to do is we have existing models for risk stratification that we use with payers now. We'd want to use your data sandbox to better identify those patients at increased risk, especially during the pandemic. We propose rolling out our systems to that patient population and then measure the decreases in resource utilization and clinical outcomes or improvement in clinical outcomes as a result. For example, this isn't a very big stretch of a hypothesis. Certain zip codes, access to a podiatrist or provider care, employment status, we are finding pre-pandemic that those are very big predictors of patients at risk. I would suspect it's significantly more in the era of this pandemic. Again, thank you so much for your time. There's a number of things we can go into more of some of the data fields. We do a lot of work here with payers to better risk stratify and to measure outcomes. And again, just honored to get a chance to share what we've been working on for the past 9 years now since coming out. Thank you for your time.
Well, that was fantastic. It was so great. You made me stand up. How about that? You know,
that's fantastic.
Great. So John, just out of curiosity, it looks like you have a pretty self-contained system. Can you share with us how your information gets from the mat to, you know, basically the right points of interest, you know, whether it's a care team or, again, I'm not exactly sure where the information ends up. So
we use cellular, first of all, to broadcast our data to our server. And then we run passively. Our design principle across the board was take the patient out of the loop as much as possible, but ideally even take the clinician out of the loop in terms of like what they have to do on a day in, day out basis. Like our care is still largely a one-to-one patient to doctor model. What we allow them to do is monitor the whole population. And if there's an alert, we then notify that clinician there's an issue, we send them a report, and then they just, if they need to be seen, they arrange to see them and do whatever it is that they would normally do per their practice.
Do they have an app or is it just passive? And then just the data is being recorded in the background and they get reached out to based on what that data says then?
Yeah, to the patient, we use a no news is good news approach. Right. They're not going to get the device and say, hey, there's an issue. They're going to get one of our nurses to call the patient and say, hey, right now, something is going on. And the first question we're actually going to ask is, how's your health today? Because holy smokes, we will get, I'm short of breath. Interesting, there's 52% reduction in all-cause hospitalizations. About half of that was from diabetic foot, but the other half were DRGs like stroke, myocardial infarction, CHF exacerbation, and COPD exacerbation. It's just this touch point into their home that we wouldn't know that this is happening in their house.
Okay, all right, thank you so much.
I'm going to turn the next question to Bill.
Super, super interesting. Trying to think if I had any questions that leaped out off the. You the impact at Kaiser, did they do that as a test, or was that a whole, a massive implementation?
It was a commercial evaluation that we ended up doing under IRB so we could publish the results.
I see.
We have probably at least an order of magnitude more in the VA. That's really where we started to get a lot of operations, along with one other MA plan that we were under NDA with. But
yeah. And is that when you think about the target for a organization like an Anthem or a Illinois Blue, is the real target is Medicare Advantage and Medicaid duals?
That's exactly right. That's the patient who is this very complex patient who drives the resource utilization.
Got it. Great. Thank you.
Sure. And if it's interesting, we also can try to do a demo. You can see it's a fairly straightforward step on it and go, but we're happy to show it.
Plummet, I see that you had a question.
Yeah, great stuff. Thank you for the presentation. Just a question again. You mentioned in your last slide, and I don't have it here, but how you intend to use the Sandbox.
Mm-hmm.
Do you need identifiable data to do that, or just trying to understand if you've done digging further in, and it's a little bit of a tactical question, but on your due diligence, I can see that you've done some, but a little bit, if you can talk a little bit more about it.
So a bunch of things, at least on security, we're SOC 2 certified. We almost always put a BAA in place so we can draw down all their data to really understand, down to their zip codes. That is, often PHI, but by really understanding where resource utilization is being used, we have a much better impact to have on those particular patients. So hopefully that answers the question.
Okay, so got it. Yes, thank you.
Great. We actually have time for just one more question. Steve, do you have a question?
Yeah, great. Appreciate that. Just curious, you said you identify those particular patients to receive the MAT. It's clearly the highest risk. What's the methodology, and then also what percentage of overall diabetics would you say ultimately end up receiving that?
Well, you estimate about 6% of a typical MA plan that's your annualized incidence from a bunch of papers. And that's an easy way to estimate how many patients would be likely Podimetrics users once they close up, or even while they're still open, that wound is still open. And what was the second part of the question? That's how you at least get a measure.
Yeah, just how you identify them.
It's almost always ICD-10 and CPT coding. One of the challenges is that most payers aren't aware that there's like 200 codes that make this up. Another one of the national MA carriers recognized that the hospital loses money on that DRG, a diabetic foot ulcer one. So they almost always bill it as septicemia. You really have to look at the secondary, even tertiary diagnosis. See, oh, there it is, an infected foot ulcer, to know why that patient came in with sepsis. It's a foot ulcer.
Got it. And then how many payer clients do you have?
Up and running, we have one national plan that we have our initial implementation, and we're in contracting with two of the other sort of big 6 or big 5 payers. We're seeing another that's not that same part, but a larger one in the, we'll say on the western half of the United States. We're seeing actually a 50% reduction in total cost of care. There in the KP data, we saw 31 to 36% reduction, but during pandemic, I think we're gonna see, because of this issue of limited preventative care visits, we're gonna see a lot more utilization, which is one of the things we want to test and understand.
Yeah. Great, thank you.
Great, thanks so much. I'm really happy to have this opportunity to share with you a bit of what we do and how this data sandbox can support our work. My name is Kapama Yalpala. I go by KP, and I'm the founder and CEO of Access Mobile. We're on a mission to improve access to health services and information through mobile engagement. Our work primarily focuses on multicultural and underserved populations here in the US and globally. Our view is that when we look at healthcare, generally we struggle to connect with members and patients remotely. This challenge tends to be exacerbated when we look at multicultural, underserved, and low-income populations. On the one hand, we live in a mobile-first world, but healthcare has been slow to become mobile-first. And when it comes to the ability to use data for what we call precision engagement or communication, oftentimes we don't find that patient engagement models are data-driven. Moreover, when it comes to the content that we deliver to connect with people and try to influence their behavior, it's often not tailored to diverse populations. We use a tech-enabled services model to optimize mobile member and patient engagement. On the one hand, we have scalable HIPAA and TCPA compliant mobile messaging technology. This has been deployed at scale, both in the US and internationally, and supports automated messaging and automated data-driven communication. On the data side of the house, we focus on population insights and risk stratification. We also focus on phone number verification, which becomes very critical, particularly for multicultural and underserved populations, and then how to tie our engagement strategies to KPIs. On the content side, we've been building a content repository that's been proven through our metrics. That repository at this point is in Spanish and English in the US. And we focus also on how we use behavioral science to nudge behavior. So as I mentioned, the way our technology works is it's really integration driven, or we leverage data sources to link to our campaigns. And then we tend to focus on the SMS channel to support communication, because that's what's most used in our target populations. The standard process for us usually starts with data analytics and insights up front, and then we focus on the message optimization to deploy to drive behavior for our focused populations and cohorts. As we learn, we optimize the approach. With COVID, what's happened with our partners is that they've had a need to move so quickly that typically our upfront data analytics and insight model has had to be compressed from a time perspective. And so we have to use our best practice insights to build those cohorts up front and then optimize them over time. Our goal ultimately is to meet individuals where they are based on their needs and preferences. When we think about need, we think about their clinical state, we think about social determinants of health and other types of data that help us hone in there and create the appropriate risk stratified cohorts. But then we have to look into preferences, because ultimately if we've created a cohort, but we're not understanding the preferences and our content is not tailored to that audience, we might not be able to drive the engagement we need. So we see that this blended model using different data sources is what ultimately drives health outcomes. Our model's proven. We work with Adventist Health White Memorial in East Los Angeles, working on with their managed care program. We've had some really great outcomes there. I'll talk about in a moment around pop health and diabetes, specifically for Latinx Spanish first speakers. On the frontier out in rural Oregon, we're working with the Medi payer on helping them manage quality metrics and appropriate service utilization in that rural context. And here in Colorado, we're doing some work with about 20,000 low-income patients, primarily underinsured or uninsured, and trying to get these people, particularly those with chronic disease burden and who have been disengaging the health sector during COVID, to get back to care. Just a few of our metrics. So on the diabetes side, we were able to see almost a 1-point reduction in A1C in a 90-day initiative where we risk stratified populations based on their profile, and those messages were in Spanish and English. We've also been able to show an increase in wellness visits and significant ROI metrics through reducing leakage in the managed care context. With regards to COVID response, we started an initiative very recently with Emory Healthcare and other partners in the Atlanta area. Many of you may know this is an area that's been hit very hard with COVID. In the model, we kind of ran into the challenge I talked about before, where we've had the need to move really fast. So we've used primarily claims data and information we can get our hands on now to basically create hotspots and what we call cold spots around COVID prevalence and incidence, and then concurrently have looked at how we categorize high-risk populations within those contexts. We do this because ultimately those variables then determine the type of engagement and communication we give to those populations based on the risk factors and the need. Someone that's in a hotspot that's also high risk, we might be sending information more around prevention or around how to access testing and treatment. versus in a place that is a cold spot, if you want to put it that way, we might be focused more on prevention. When we look at the landscape, we don't see many groups that are really focused on this construct of social and cultural awareness and health equity and using data to drive precision messaging to ultimately get people to care and get them the impact they need from a health perspective. Zach, who's on the call now, is our Director of Behavioral and Data Science. He runs this division of the business. The president of the company was the head of MGMA and led the national data analytics business here in the US for them. And my other colleagues are also well versed in this work. So what we like to do at the Sandbox is really see how we can become more attuned to risk stratification faster, to really help us with our engagement strategies and to ensure that we can get people to either the care they need or to the COVID-related services they need. And so this relates also to controlling for implicit bias, but then also looking inside of that database to underserved cohorts and how risk stratification for those specific populations can mitigate adverse health outcomes. Thank you.
Great, thanks, KP. Nice presentation. Can you maybe walk us through, how you basically engage with, the population to, do the basics of understanding, their communication preferences, things like that? I mean, what does that outreach look like? How are you supplementing and helping the plans find phone numbers and all that?
Right. So usually it'll start with an initial pain point. So I'll use the diabetes use case. So we're working with one of our partners on basically Spanish first speakers in the urban setting. And these people specifically have been hard to engage. So the first issue was, what's the cohort of patients that we need to address? The second issue is, to your point about phone numbers. So then we basically have an automated phone number validation system. So we can basically plug in any phone number in the country and figure out what type of number it is it active, those kind of things. So usually you find that most groups don't really know how many phone numbers they actually have. They'll tell you, oh, I've got 100,000 phone numbers, but when you run it through the system, you might find they have 69,000, for example. So once we know, that kind of drives the initial cohort, then we layer on clinical and SDOH segmentation. And we have some hypotheses around what we think will drive the behavior for each cohort. So in our diabetes initiative, we had one cohort that was not on medicine and was controlled in terms of their diabetes A1C. We had another group that was on insulin and controlled. And then we had another group that had uncontrolled type 2 diabetes and was not compliant, right? And so each one of those cohorts got a different messaging regime. And that's actually what drove to some of the metrics you saw before.
Great, thank you.
Mm-hmm.
Great, let's turn our next question to Plamen.
Thank you, KP. Very exciting and aligns very much with our push to have a broader view of healthcare, integrating health and social determinants. One thing that I wanted to better understand, you have analytics and you have engagement as part of the two pieces. I wasn't entirely sure how do you combine those? Can you speak to that a little bit? I missed that part.
Okay, great. So I'll give the framework, and then I think Zach, who's on the line, he might want to talk a little bit about that, our data scientist. So first, there's analytics on the front end to create the messaging cohorts, right? So, and that is an upfront process. And so we have a data science team, we have some partners we work with to create those cohorts. Then we create the campaign to drive the metrics, and we have automated messaging that's fairly sophisticated. So we can use really detailed segmentation and automate that based on those risk cohorts. Then on the other side of it, then we have to look at what happened. So we look at both the engagement statistics, like opt-out rates, click-throughs, but then we also look at the health-seeking behavior and the clinical outcomes. And it's like a full cycle approach. But Zach, if you're on the line, you want to talk a little bit about that?
Yeah, sure. The only thing I want to add to that, KP, is that, with mobile engagement, we have kind of very immediate outcomes. Like KP mentioned, we can see if somebody opted out right away, or if they clicked on a link to access information right away, even if the health outcome that we're shooting for is 6 months down the line. So with the upfront analytics that we're doing, we can also iterate messages very quickly to allow for higher engagement rates over time.
Great. So there's a loop back end to end. So thank you.
Yep.
Great. Let's turn to Bill now for the next question.
Thanks, KP. Super, super interesting. And, I think solving a problem that's a real issue. Can you just, tell me a little bit of examples of things that you saw in your, you referenced the kind of the three significant interventions you did, or the campaigns that you guys did. What were some sort of key learnings in terms of the culturally specific, either communication, outreach, engagement? What did you learn? What did you see?
Great. So I'm going to tag team with Zach on this. So I'll talk a bit about what we're doing in Atlanta, and then Zach, you can talk about other use cases. So one of the things that we're doing in Georgia that's, we think, fairly innovative is we're using what we're calling a connected community of care model. So one of the big issues in terms of COVID-19 and engagement of African-American and other populations is trust. So part of what's really important to consider is the vehicle through which the message is coming from, and is that a trusted channel? And so we know, like, for example, partnering with Emory, that in the Atlanta area, there are community organizations and other groups working in the health ecosystem that are trusted channels. So while we're working with the health provider on one side, we're working with other community partners as a trusted vehicle of communication, because we know we get higher engagement, right? And so when you kind of connect those elements, it's more likely that someone in one of those hotspots, if they're getting the message through the church, it's more likely they respond and take action than in some cases if that message is coming from Emory Healthcare. So it's fairly, there's some sophistication there around how a matrix of compliance and other things and how we source data, but that's one element of how this works in practice. But Zach, I'd love for you to share some of our other case studies.
Yeah, I think one of the interesting things that we see is that microsegments kind of come out of the messaging that we do. So when we were working in LA, we found that Spanish-speaking women between the ages of 40 and 45 were 3 or 4 times more likely to engage with messaging and 3 or 4 times less likely to opt out of messaging. So we know that this is a cohort of people that we can actually engage with more and be more proactive with, because we're not worried about them opting out very quickly. Another insight that we got that was interesting is that, generally speaking, if you have a database of phone numbers, those over the age of 50, about half of the phone numbers are going to be landlines that you can't text message. It's just, we see it across the board, internationally and domestically. But what's interesting is in rural Oregon, we found that the dual eligibles, the Medi-Medi populations, they were hard to reach because they didn't have landlines, but they engaged like a much younger population. So they were really, really engaged. They were very unlikely to opt out, and they looked very different than an older population that was not dual eligible. So what we did moving forward is that we're actually segmenting not just the messaging based off of age and demographics, but also dual eligibility, because we know that even though they're harder to reach technically, because we can't send them a text message, they're going to be very engaged if we can reach them at all.
Hi, thank you very much. So my name is Richard Graves, and I'm the Chief Operating Officer and co-founder at Sorcero. And I'm here to talk today about how we're proposing to help power pandemic response with language intelligence. So we know that the real world problems that payers, healthcare providers, and treatment providers face today require expert analysis informed by biomedical and scientific content. Sorcero is an AI company that provides language intelligence. And what we found is many of the AI solutions that have been applied to the health insurance and healthcare field often struggle to actually integrate and understand that specialized content. What we do at Sorcero is we infuse AI with the domain expertise that it needs to understand and power insights from the structured and unstructured content that these industries operate on to power those for decision support on big problems like the pandemic we are facing today and future pandemics we will be facing at scale. Our platform enables language intelligence by integrating this technology with the deep domain expertise out of the box of the most advanced models that have been developed in a continuous integration environment. This allows insurance and life science enterprises that we serve today to seamlessly integrate it and to build applications that could drive novel capabilities powered by a level of accuracy and understanding that isn't achieved either by specialty models that are designed for this space or general language understanding and general domain AI that has not been tuned into or remapped using our capabilities. We use hierarchical layers of ontologies, lexicons, and other capabilities to actually build this out. Now, this insight was based on the expertise of our team. Our founder and CEO, Dipana Das, actually built global public health platforms that were used in 20 countries for the Global Health Accuracy Incubator, working for Gates and Bloomberg and others. And Walter Bender, our CTO, who also developed the cognitive tower that provides the heart of the capability of our technology, was also the co-founder and executive director of the MIT Media Lab. Myself, I've worked in scaling data science-driven startups to past 9 figures and becoming market leaders in their segment. And Ketan Shah, VP of Product, actually led some of the largest product portfolios of OpenText, taking insights from unstructured text in an enterprise-to-enterprise environment. So what we're talking about using language intelligence today is to actually improve patient outcomes via rapid response delivery of COVID-19 guideline compliance. We know that payers like Anthem, Blue Cross Blue Shield are paying out claims to healthcare providers that aren't adhering to the latest medical guidelines, of which there's been 11 updates just since May 12. And that's both causing negative outcomes for patients and large costs from outdated and deprecated treatments. But the evidentiary patterns of that are buried in the highly technical medical language, and to find the timing and the alignment of those treatments with those guidelines is very difficult. What we do is we continuously ingest the latest medical guidelines, and we're proposing to work with the sandbox data of Anthem AI, particularly in the diagnostic and claims domains, and mapping it to the nodes in those medical decision trees to score the use of those procedures by healthcare providers. This can speed up medical investigation process with other payers. We've done that by 28%, and improve patient outcomes, reduce healthcare costs. What we do is apply our cognitive tower, provides that deep domain understanding to those guidelines and claims. We want to show the particular areas, admit dates, diagnosis codes, and provider information, and map that to treatment codes, outcome codes, and the discharge date. Mapping that to those guidelines and finding the best match in adherence and quantifying the potential improvements against those guidelines and clustering the healthcare providers that could be targeted to both be updated or to assess their claims. So we have a tool that can do powerful biomedical content ingestion. We can take a wide variety of structured and unstructured sources, including the unstructured content that is within the structured relational database that you're providing the data sandbox, from diagnostic reports to claims forms. We then provide auto tagging and tools for medical understanding that can rapidly process complex medical literature 10 times faster than traditional sources, identifying things like symptoms, disease severity, disease progression, and more. We actually allow our customers to view and compare those textual and structural changes between guidelines, including the COVID-19 guidelines, in real time, providing a level of analysis and making it into a software-defined medical decision tree. That allows us to track those changes from the published literature, map to decision nodes, and we can actually update those in real time and take in that claim data. We can understand that through the complex interdependencies of those texts and concepts. We enrich that, and together that creates a graph of interdependencies. Graph-based AI is something I know some of the judges have worked with, and that will allow us to drive insights and flag claims with those outdated treatments, and to find basically the speed of adherence with clusters of healthcare providers. That can both allow you to target them for adoption of upgraded treatments and diagnoses, look and actually analyze the differences in performance, and allow you to provide those entire healthcare provider networks, or flag claims that need to be adjusted as quickly as possible. As a case study, we're doing that today with some very large companies, including with Roche and Smart Diagnostics. What they said about our technology is that they said they can rapidly identify changes in new versions of medical guidelines and adapt their smart testing algorithms. We're being able to hope to take that technology to Anthem and Blue Cross Blue Shield. Thank you very much.
Thank you, Richard. Very interesting, pretty advanced stuff. So One question that I have is, I'm not sure I fully understood. How is the system being used? So is the intent to be connected into a clinical decision support system, or can you clarify that?
Absolutely. So currently, we are powering clinical decision support through medical guideline ingestion from raw literature, maintaining and updating structured medical decision trees and allowing that to be API accessible. We've also separately been working on health claim adjudication, where we were using our biomedical textual understanding of medical notes to actually support that adjudication and medical investigation process for payers. And we're proposing is to take these technologies and put them together. I know that you've worked on probabilistic graphical models, and we take basically advanced natural language understanding, augmented with that deep domain expertise on ontologies, and then we want to map that with the graphical AI so that we can actually cluster both claims and healthcare providers and say the best classification of fit and the time it's been taking them to actually adopt new recommendations on the guidelines for medical treatment, so that you can have a vision and insight into the speed of adherence, the cost of the time lag of adherence, and the improvements of both patient outcomes and savings that can come from getting those healthcare providers into modern guidelines and more updated treatment options.
So I'm sorry to continue. So your target user is the physician, or is the app the consumer, or a little bit?
In this case, this would be actually the payer. So we would want to be providing both insights on the claims adjudication so that you would have an additional data point on whether the claims that are coming in from those healthcare providers are actually being up to date and matching those guidelines and saying, okay, it looks like their treatment is really based, it really closely maps to maybe version 9 of these guidelines. In fact, we know there's reduced cost of better outcomes if they were updated to version 11, for example. So that both allows you to respond on payout of claims and do outreach to healthcare providers from the payer's perspective, and then give them access to a software-defined medical decision tree that they can use and use as a reference when they're both looking at the recommended treatments and how they submit them for payment. So
Got it. Thank you.
Adjudication of that.
I'm going to go to Addison for our next question.
Yeah, so again, Richard, I think, again, probably still along the lines that I'm just trying to figure out from a payer perspective, would be use you pre or post adjudication given the number of, I'll just say, claims that we process on a given day. You know, you're talking billions of, you know, operations. I'm just trying to figure out where this would fall within.
So with our other payers, we've used this for both the process of medical investigation on overbilling on adjudication. We've also, one of our lead data science advisors also worked at a very large scale on prior authorizations. We think that this can augment and guide the prior authorization process. And we also think that as you do outreach to your healthcare provider networks, we'll be able to provide software-defined guidelines that they can tap into and use and say, okay, we're in alignment with the payers, with both the NIH recommended guidelines and the payer. And so they can streamline operations, get access to that software-defined information or outreach.
Thank you.
Hopefully that helps you answer your question.
Our last question will come from Steve.
Yeah, great. Appreciate it. Certainly a lot of great advanced opportunities here that could very much inform even medical policy, payment policy, things like that. So appreciate those thoughts. Can you talk a little bit more about your client base and kind of what outcomes you've been able to achieve with particularly your health plan customers?
Absolutely. So we're a relatively new company. We're only 2.5 years old. We recently graduated, I think last year, from Plug and Play InsurTech and Health, and completed the Startup Creosphere program, which is the European Union's leading digital health program, this spring. We've been working with a major life and health insurance conglomerate that has 41 million customers. We've been working with a subset of them. They have about 1.5 million customers in a European country, their health insurer payer. We've been providing them with enhanced intelligent medical investigation, adjudication support, and access to structured knowledge around their coverage and claims. And we've identified that we'd be able to save them tens of millions of euros in medical overbilling and analysis on this tool. We're also working with Roche in their diagnostic information systems on their smart diagnostics platform, which they will be rolling out. They already have in North America and Europe. We have 8 enterprise customers, and we've been working with insurance, life, health, and accident primarily, and then some of these life sciences companies, particularly on where that clinical decision support and ingesting the scientific intelligence that guides treatment outcomes.
Great. Yeah, thank you.
Thank you so much. I appreciate the question.
Hello, everyone, and welcome back. Matter is pleased to bring back our CEO, Stephen Collins, who's been sitting with our judges as they worked through all of the fantastic presentations today, and has our scores and our winners. So without further ado, Stephen.
Thanks so much, Gina. Thanks everyone for waiting. We started this program with entries from all over the world. We whittled them down to the 9 who presented today. As Gina mentioned, the judges have been deliberating. There was a lot of really great discussion. I got to be a fly on the virtual wall for the conversation. And it was clear that the judges really appreciated the opportunity to learn about all of the solutions and that many of the proposals really resonated with the group. That said, the judges coalesced around 2 winners who will each get the opportunity to pilot as well as a 1-year Matter membership. So with no further ado, the winner of the behavioral health track is wayForward. Congratulations to the wayForward team. I would do a drum roll or something, but you get the point.
Thank you.
Congratulations. And the winner of the Data Sandbox track is WiserCare. Congratulations to the team at WiserCare.
Thank you. That's great news.
That's awesome.
Indeed. Thank you to all the teams who participated in this process. As I mentioned, my observation from listening to the conversation with the judges is that they really appreciated many of the presentations, learning about all of the solutions. And thank you as well to the judges committing a good chunk of your day to this, really lending your expertise and helping select the winners. And thanks finally to the team at HCSC and the team at Anthem for entrusting us with this partnership. I hope you all have a terrific day. Stay safe and look forward to seeing many of you again soon.